Good evening and a warm welcome to our third webinar of this EACLIPT series. My name is Dr. Marta Jackowska. I work at SWPS University in Poland, which is a co-organizer of these events. And so today is our third webinar. In September, we will have a fourth webinar, and all of our webinars are leading towards our conference EACLIPT 2022 in Warsaw, to which you are all welcome. I am delighted to say that we have an amazing lineup of speakers, and our keynote lectures include Professor Emily Holmes and Professor Gerhard Andersson. Today, I have a huge pleasure to introduce you to not one, but two keynote lectures. First, we have Professor Svenja Taubner from University Hospital Heidelberg. And Professor Dr. Shelley McMahon from University of Toronto in Canada, and Professor Martin Dibany will just say a few words about them in a minute. As before, following our keynote lectures, we will have a short break, and then we will proceed with our panel discussion, where we'll have Dr. Gita Jacob from the Gaia Group in Hamburg, and then we'll also obviously have Professor Svenja Taubner and Dr. Shelley McMahon, and Martin Dibany will be the host of the panel discussion as well as one of the panelists. And last but not least, I really want to warm our audience who are joining us live. Thank you very much for signing up to our webinars. And now I give the floor to Martin, who will say a few words about our speakers. Thank you.
Thank you, Marta. We're delighted to have the pleasure to first listen to our two guest speakers. We have a great lineup. I'd like to first introduce Professor Svenja Taubner, who's a psychologist, psychotherapist, as well as a certified psychoanalyst from the German Society of Psychoanalysis. And Svenja is specialized as a trainer and a supervisor of the contemporary psychodynamic mentalization-based treatment. She, in her work, specializes in the development as well as the evaluation of intervention and prevention programs for families, individuals, and mental health professionals. So she'll be giving a talk on the initial development of borderline personality disorder, and as well as mechanisms of change, mediators and moderators. Svenja is director of the Institute of Psychosocial Prevention at the University Hospital of Heidelberg since 2016. And she has published quite a lot. Her main research interests include, of course, mentalization, but also psychotherapy, personality disorders, aggression, as well as competences of mental health professionals. So a warm welcome to you, Svenja. And then I may introduce Dr. Shelley McMahon before her talk, if you agree, Marta. Yeah? Okay. So Svenja, welcome to this webinar. We're looking forward to your lecture, and the floor is yours.
Thank you. Now I can see the slides. Great. We have a little delay in what I'm seeing and what I'm saying. So I hope this will work out and I won't get too confused about this. Thank you for the invitation. I'm really happy to discuss later on with you all, with Gita and with Shelley and with Martin. And I will start talking about the work that we have been doing in a consortium called Treat Me. And I want to talk about change mechanisms in the treatment of BPD. But first of all, I have to talk a little bit more about change mechanism in adolescence in general. Please, next slide. I cannot change the slides myself, so I always have to say change. So this is the European network that I'm talking about. It's called Treat Me, and was a cost initiative, the human cooperation in science and technology. And here you can see a picture. We actually had 30 countries in Europe involved. And this was a picture from the training school in Nicosia in 2018. And we were dedicated to create this network of researchers to look at the psychotherapeutic treatment of young people with mental disorders. Next slide, please. So our main aims were to establish this network, and at the same time to carry out some huge and large-scale reviews about moderators and mediators, designs and measures for psychotherapy with young people. Next slide, please. So this is not to confuse you, but this is how a cost initiative looks like. This is the management committee, and you see the working groups, and in red highlighted the working group that I was happy to be the leader of the working group that was dedicated to work with mechanisms of change. Next slide, please. So these were our members. It was an international group. We had 18 active members from 11 countries. And Erkki Heinonen from Finland and Sonja Pročić from Serbia were my vice leaders. And the work that I'm presenting today was also very much carried out by Jana Volkert from Germany. Next, please. So we know that mental health is a major issue for young people. And a lot of the mental disorders that we're looking at actually start in adolescence. So 75% of the mental disorders emerge before the age of 25. And so we should look at prevention, obviously. So this is what my professorship is about. But we should also see that we address these mental disorders as early as possible with intervention. However, we have a lot of different psychotherapy models, more than 550 different models that can be applied to young people. So it's not as much as we have for adults, but still, we don't really understand how these therapies work, and we should know more about how those therapy models work to enhance treatment outcome. Okay, so the idea to do research on mechanisms of change is to better understand how they work and to improve treatment afterwards. Next, please. So how can we understand mechanisms of change? We have some statistic variables that we can apply. So the most known probably is the moderator, but the moderator cannot really be changed. I mean, here we can look at what works for whom. So is there a treatment that's better for girls? Is there a treatment better for boys? Is there a treatment better for BPD specific or depression specific? So this would be the moderator, but what we will be looking at now is the mechanism of change. So what kind of interventions do we need to apply for personality disorders, for example, that's actually leading to change, and what can be discarded that we still carry with us from our bigger psychotherapy models that maybe isn't really leading to change and we don't need it after all. And to look at these mechanisms of change, we look at so-called mediator variables. So this is something that has to change in the treatment, and this change leads to a change in outcome. So this is the basic idea of a mediator. Next, please. So in our change models, we have the specific change variables and the more contextual or unspecific change models. And we have a lot more knowledge about the contextual variables. So we know that empathy is really important and the therapeutic alliance, but especially in the treatment of personality disorders, we want to know a little bit more specific. And we have these specific psychotherapies dedicated for the treatment of BPD. And so we want to know more about those. But the general knowledge, next slide, please, is really scarce. So there was a very nice review by Kuipers and colleagues. They looked at the role of common factors and psychotherapy outcomes and in relation to specific factors. And currently they summarized the state of the art that was for adult treatments, that no common or specific factor meets the criteria to have a strong empirical base. So after 150 years of psychotherapy, we still don't really know how it works. So this is where we're at. So this is where we wanted to start and to look specifically at adolescents and their treatment. Next, please. So we did a training school with Pim Kuipers and Markus Huibers, and we agreed firstly on what is a mediator. So we know what to look at in the studies. And we had quality criteria that have been postulated by Kasten in 2007 already. And they are important to estimate if the trials are actually measuring mechanisms of change. So we need to have RCTs. The mediator variable has to be measured with valid and reliable measures. We need to have a process design. We need to have several measurement points for the mediator, and we should actually compare different mediators and not just one. And to have the perfect study, we would need to apply different dosages of the mediator to have an experimental design to be really sure that this is a mechanism of change. Next, please. So we created a search string. Don't look at that. It's really complicated. But we really wanted to have a broad view on the knowledge of mechanisms of change in the treatment of adolescents in psychotherapy. Next, please. So we performed this search. It was done in 2020, and we did an update now in 22. We included studies from all geographical locations written in English. It needed to be an RCT. It needed to have a mediator included. It needed to be a psychosocial intervention. And we wanted to look at individuals between 10 and 30 later. We narrowed that down to between 10 and 19. Next, please. We published the protocol for this review that you can read, because what I'm presenting now is actually submitted, so you cannot read it yet, but I hope you can read it soon. Next, please. So these are the research questions that we were looking at. So to identify which mediators in theory of change have been studied at all across different psychotherapy models, to identify if there are adolescent-specific or disorder-specific or treatment-specific mediators, and to critically evaluate how the methodological approach in the current research available looks like, and to comment on the robustness of the evidence here. Next slide, please. So what we did in this huge group of people was that we actually looked at over 1,000 full text, and in the end included 106 studies that have dedicated their research to assess mediators of change in adolescents. So this is the state that we are at, and I will present you the results now for the first time. Next slide, please. So we were able to identify 6 different diagnostic categories, and as you will see, there is no borderline personality here included, because we didn't have more than 3 RCTs actually dedicated to borderline. We had a lot of studies dedicated to anxiety, depression, externalizing disorders, substance use, and PTSD. But the BPD trials were actually a bit hidden, and I will go there in a minute. So we had studies where mostly the participants were female, and we had more than 19,000 participants included here. We have a very strong dominance of US-based studies, so 74% of the studies were actually conducted in the United States, and only a few in Europe, and almost no study outside the Western world. The studies were mainly from cognitive behavioral therapy. I'm sorry, I have to close the door because my dog is barking. So I'm back, sorry for that. So mainly CBT, followed by humanistic approaches, systemic therapy, educational approaches, and only one study in psychodynamic psychotherapy. And guess what? It was MBT. Okay, next slide. So what we found was a huge variety of statistical models. I will not go into detail here because I don't have the time, but you see that there is no agreement in the research on mediators, what kind of statistical model should be used. And there's also not a real agreement on the estimation technique to test the indirect effect of the mediator variable. 40% used bootstrapping, but there were also very, very different models. And in terms of the quality, we also found that only a few studies fulfilled all the quality criteria from Kestin, for example. And a lot of studies didn't even report the specific estimation technique. So it's really difficult to replicate these studies if you don't know how they calculated the mediator at all. Next slide, please. We did a qualitative synthesis of the mediator categories. I think this is also, for me, that was very interesting to see what kind of mediators were actually looked at. And the numbers in brackets here are actually the mediation tests that have been performed. So we have cognitive mediators, 80 tests about that. We have family-related mediators, so that was the second largest group, behavioral, therapy-related, relational, and only a few studies really looking at emotional mediators. Next, please. And we had some subcategories of these mediators that you can see here. And we try to look at in this rating, what are the candidates of mediators that should be looked at more. So what kind of mediators turned out to be actually significant and to explain change above others that we could find. So really to summarize the existing knowledge that we have on mediators. Next, please. So in total, we had 252 statistical mediation tests, but these tests were actually drawn from 177 different measures. So it's very difficult to compare these results because they basically, even though they claim, or that like cognitive mediators, for example, we have a huge variety of different constructs that are behind this. And so, well, but we came to a conclusion. So promising mediators for adolescents are changes in negative thoughts, dysfunctional beliefs and metacognitive skills, family functioning, parenting skills, successful engagement in therapy activities, and increased impulse control. So these were the mediators that were more successful in explaining change than the other mediators. Especially therapy-related mediators did not seem to be very significant because, I mean, those are not classical mediators from the definition of a mediator. And in terms of the relational, emotional mediators, we don't know a lot because they're largely understudied. So we could say we have adolescent-specific mediators, especially with regard to peer relations, for example, and to family relatedness. But we did not find any disorder-specific mediators here. And strikingly, there was a tendency within these studies to just test the change mechanism of the specific theoretical model that the therapy was dedicated to without considering any other possible change models. And we had a striking lack of good study quality. Only 11 studies could be qualified as having an overall good study quality. Next slide, please. So with Okay, I should be back now. Sorry, we just lost the connection. So in this evidence rating, we did not find strong evidence for any disorder-specific mediator here, as you can see on this table, I hope. But this was mainly due because the study quality was so low in the studies that we looked at. Next, please. So what about personality disorders, as I promised? Next, please. So we know that the evidence base for the treatment of borderline personality disorder is okay. In the latest Cochrane, we had 16 different types of psychological treatments that have been looked at. And of those, 2 stand out a bit more, which is dialectical behavior therapy, DBT, and mentalization-based therapy, because those were the therapies that are most studied, and they seem to be fairly okay to reduce borderline personality severity, self-harm, and suicidality and depression. But also here we have problems in low-quality evidence because, and there's some uncertainty left over, so we need more studies here as well. Next, please. Now, coming back to the mediator question, I looked at the studies that actually had borderline personality disorder adolescents in it, but they didn't really claim to screen for them because it was common not to diagnose borderline personality disorder in adolescents. So they mainly ran under the label of depression, although they included a lot of borderline patients in here and screened for self-harm. And the studies here actually looked at DBT and MBT. So there was 1 MBT study and 3 DBT studies. But the Melum studies, they did not look at the classical change theory related mediators, but they looked at more common factors. Whereas the latest DBT study here, they actually looked at emotion regulation changes, and they did find that changes in emotion regulation lead to changes in BPD. And the Russo study from mentalization-based treatment looked at the question if changes in mentalization and attachment leads to reduced self-harm, and this they did actually find. But you can see here we have 2 studies that looked at mechanisms of change so far in adolescents. So it's very far, as I said in my title, to conclude causality here. Next, please. And we have another problem because we don't have this evidence for the effectiveness of psychological therapies for adolescents like we have in adults. There is a recent systematic review that was published in PLOS ONE in 2021, who for the first time pooled the data for adolescents with BPD. And the results are in the following slide. So next, please. So there were only 10 trials so far that could be included in this review that looked at BPD or BPD features. And they actually did not find superiority over the treatment as usual. So it's very difficult to derive any conclusions on the efficacy of psychological therapies for BPD in adolescents. And one of my tentative conclusions here would be that when we look at the general mediator results, we see that we actually do need maybe adolescent-specific change models. And the therapies that are mainly applied to adolescents at the moment are taken from the adult BPD treatment, and maybe they're not adolescent specific enough. This would be, well, this could be discussed later on. Next slide, please. So I'm coming to my final slide here. It's actually a little bit devastating, the results that we have from our review. Even though we did find 106 studies, we are still so far from causality or from conclusions what's really working in psychotherapy, mainly because people have just been very restricted to study their very limited ways of their own psychotherapy model and not looking beyond. So it's too early to draw any definite conclusions here. And we maybe should look at these recommendations from the Lancet Psychiatry that we really need to identify the candidate mediators to move beyond the current status that we have at the moment, to have 550 different models of psychotherapy and still don't know what works for whom. Next slide. And so I come to my end here, and thank you for the attention and sorry for the problems in the technique here.
Thank you, Sven. That was a really interruption. Going as you set the stage for a lot of work that is to come, and to better understand these mechanisms of change, and perhaps also a lot of questions concerning the early years, namely adolescence.
Yeah, actually, one slide was missing somehow. I don't know where that went. So I had a slide on change mechanisms in DBT and MBT, but maybe we can come back to that later in the discussion.
We will discuss that, certainly, and to introduce the later stages of development as well as DBT, we have honor and privilege to have Dr. Shelley McMahon with us tonight. In the Department of Psychiatry at the U of T in Canada. Shelley has received several awards, namely for her psychotherapy research, including the recent award for achievement in the field of severe personality disorders from the Personality Disorder Institute at the University of Columbia and Cornell in New York. She is president of the Society of Psychotherapy Research. Her research interests include borderline personality disorder psychotherapy, such as DBT, and the mechanisms and mediators of psychotherapy outcome. She's currently acting president in the newly established World DBT Association, so it's a real honor and pleasure to finally meet and collaborate with Shelley McMahon. Shelley, the floor is yours.
Thank you for your very generous introduction, Martin, fellow Canadian. So first of all, just thank you everybody for being here, and thanks for the opportunity to speak to you in this webinar series. I was invited to talk about psychotherapy of borderline personality disorder, and what I've decided to talk about is some advances in the field. Next slide. So the plan for my presentation is as follows. What I want to do is just very briefly review what we know about the effectiveness of psychological therapies for BPD. And I want to talk about some of the current challenges in the field, and then focus on some of the ongoing future directions that are underway to improve the effectiveness of existing therapies. Next slide. Actually, next two slides. Move to the next one. Thank you. So, if we look back on the history of treating people with borderline pathology, there's been significant progress. If we look back to between 1930 and 1970, when classifying patients was really tied to how analyzable they were in psychoanalysis. So patients were either neurotic or psychotic, and those, of course, who were viewed as being on the border were people who were really difficult to treat and considered untreatable because of their tendency to regress into borderline schizophrenia. It wasn't until around 1967 that Otto Kernberg really expressed a lot more optimism about the treatability of these patients who were viewed as borderline, and he really thought that patients could be successfully treated with psychoanalytic therapy. Other analysts disagreed with this, and really pejorative views of people with borderline pathology and their ability to successfully engage in psychotherapy were quite common through the 1970s, when psychoanalytic therapy was the dominant approach. In 1980, BPD became an official diagnosis in the DSM-3, and it was in 1993 when Marshall Linehan, a radical behaviorist, introduced dialectical behavior therapy. And at that time, she published the first trial demonstrating that therapy could be effective for people diagnosed with borderline personality disorder. 8 years later, Bateman and Fonagy demonstrated the effectiveness of a mentalization-based day treatment program. Next slide. So the evidence base for therapies for people with borderline personality disorder has really grown considerably over the past 3 decades. Just briefly in this slide, there's at least 14 meta-analytic studies that have assessed the evidence base of psychotherapies for BPD, the most recent published in 2022. And from this list, you can see now not only, are there a sufficient number of RCTs to enable people to conduct meta-analytic studies for this condition, but also we've got very focused meta-analytic reviews, such as the review that Svenja referred to on Adolescents, which was recently published, and meta-analytic reviews of specific therapies for borderline personality disorder, such as DBT and mentalization-based therapy. So there's a robust evidence base for the effectiveness of therapies for BPD. Next slide. So, and Svenja perhaps summarized this in the last, so I'll just briefly highlight here the Cochrane review that Svenja had referred to, identified 75 RCTs. Of these, there are about 16 different approaches analyzed in that trial or in that meta-analytic review. The majority of the trials that had been evaluated were focused on DBT and MBT. Dialectical behavior therapy had the highest number of RCTs, so out of 75, 16 focused on DBT, 7 focused on mentalization-based therapy, and the treatment lengths ranged. So I think I've got 0 there, which is incorrect, but they range certainly up to 36 months. I don't think anything was 0. That's a typo. But in short, the findings from these trials indicated that BPD-specific therapies are superior to treatment as usual. There's not a lot of comparisons of specific treatments to active comparators. So while that's limited, if you compare the effect sizes of specific treatments, there's really no evidence to suggest the superiority of one approach over another. Next slide. So depending on the specific outcome domain, there's quite a bit of variability in effect sizes reported across these meta-analytic trials. And these meta-analytic trials really vary in terms of their methods and inclusion criteria. But the effect sizes in general are moderate and range from small to large. If we look at effect sizes for suicide and self-harm, they seem quite large. If you look at effect sizes for BPD symptoms, they're about moderate to large. For general psychopathology, psychosocial functioning, they range from small to moderate. For depression, small to large. On average, dropouts are around 25%. Next slide. So what are some of the current challenges? Well, if we consider the results of this last meta-analysis that was conducted in 2022, treatment effect sizes actually in that meta-analytic review were really modest, and they really ranged, and this is just based on the largest meta-analytic review, range for the most part to small to medium effects. So certainly we could do better in terms of the efficacy of treatment and the impact on outcomes. And I think the other important thing to consider is that the effect of treatment doesn't necessarily mean that a treatment is clinically or a change has been clinically meaningful. there's really little evidence that the change on outcomes meets cutoff for clinically meaningful improvement. From the most recent meta-analytic review that was conducted by Stofers, they found that actually BPD symptoms was the only outcome domain that met cutoff for clinically meaningful improvement. And then furthermore, despite improvement, and there's certainly evidence across trials that people do make gains in psychosocial functioning, a good 60% of people still exhibit pretty poor psychosocial functioning by the end of treatment. So it's a problem that needs to be addressed. So there is, next slide, please, thanks. So there is a need to improve the clinical and cost efficacy of therapy. And one way of doing this, of course, is understanding the mechanisms of change. We've already heard that if we can understand the therapeutic effects, then we can potentially refine therapy, and we can use this information to try and personalize therapy, try and tailor the interventions to diverse client needs, and ultimately improve our ability to implement treatment in the real world. So empirical studies on processes of change and statistical mediators and therapies of personality disorders, as we've already heard from Svenja, it's a really emerging field. The literature on mechanisms of change and therapy could be classified really across four main themes. One is emotion regulation, so we're talking here about things like distress tolerance, the ability to be aware of and accept emotions, the ability to have balanced emotions, experience positive and negative emotions. Two, the ability to learn concrete ways of coping, so coping skills. The ability to shift mental states, so increase mindfulness, attentional control, reflective functioning, metacognition. And then finally, the ability to develop and cultivate a strong therapeutic alliance, so the alliance between the therapist and client. And there's research really that falls in these four areas, and some evidence to support these constructs as mechanisms associated with evidence-based therapy. Next slide. So while, the availability of effective therapy certainly, I think, has changed dramatically how we see people who are diagnosed with borderline personality disorder, there's still a lot of work that needs to be done in terms of making therapy more accessible. No therapy is going to be effective if we actually can't get people to access it. It stands no chance. So there was a recent study that looked at the availability of treatment across the world, and the main findings from this study, it wasn't any surprise, is that there just are insufficient numbers of mental health care providers to be able to respond to the estimated number of treatment-seeking individuals with borderline personality disorder. Only a very small fraction of providers will ever obtain training or certification in a BPD-specific specialist treatment. So the implementation of specialist evidence-based treatment alone, or training clinicians to learn these treatments, it's just never going to possibly address all of the public health needs. So it means that we do need to consider a range of alternatives, and this is where there's increased focus on generalist models, on stepped care models, or staging treatment, as well as briefer treatments. Next slide, please. Thanks. So there's ongoing work, I'll just say a moment, but there's ongoing work to improve the effectiveness of psychotherapies for borderline personality disorder. And this really falls into four main categories. I'll just highlight the categories and then I'll say a few words about each of these areas. First is research focused on abbreviated forms of specialist therapies. Second direction is research to evaluate stepped care models. And I think there's more research probably coming looking at staging of treatment. There's also a third direction, is research that's focused on developing and evaluating adaptations to first-generation BPD-specific therapies, really designed to target comorbid subgroups, namely post-traumatic stress disorder. And there's also an increasing focus on research to improve the efficiency of therapy by targeting active mechanisms of therapy. So we'll just leave it on that first slide. So there is a common opinion probably amongst most clinicians that people with personality disorders, in particular borderline personality disorder, are going to require intensive long-term treatment. Actually, if you go back one slide, I'll just say a few words on that last slide because I hadn't done so. Thanks. So shorter versions of therapies for BPD, I think, are an important direction, given the awareness of the problems of accessing therapy is a significant one. There's many possible directions we can take, but abbreviating therapy may be at least one solution to the problem of increasing access. So one question is, well, how effective are brief therapies? There was a recent meta-analysis conducted by Spong that addressed the question of the efficacy of brief interventions. They were able to identify 27 randomized controlled trials. Brief was defined in this meta-analytic review as 6 months or less. On average, they found that treatment lengths were around 3 months. There were a range of models that they identified in this review, including emotion regulation group training, manual assisted cognitive therapy, system training for emotional predictability and problem solving, so the STEPS approach, and DBT skills training, just to name a few. The most commonly studied brief model was DBT skills training. And the findings from this research showed that brief therapy showed modest efficacy. So shorter term treatments seem to show the greatest reductions in borderline symptoms, and the effect sizes were twice as high if these brief, oftentimes group-based interventions were delivered in the context of some additional support. So that was an interesting finding, and the thinking is that maybe if people just in standard non-specialist treatment might also be given adjunctive brief, for example, DBT skills training, that might be a way to boost the efficacy of their treatment. There was a caveat raised by the authors in this meta-analytic review, and that's that there just was considerable heterogeneity in this review. So I think the takeaway is that short-term interventions may be effective. It is unclear at this point how durable the symptom change is. Next slide. So my group recently addressed the question of whether a brief version of standard dialectical behavior therapy would be good enough relative to 12 months of standard DBT. And based on our research evaluating DBT, it appeared that really the vast majority of change people made within the first 4 months of treatment, and oftentimes were maintaining their gains after that point. So we theorized that really by 6 months, actually the outcomes may not be considerably different than people who received 12 months of treatment. So we designed this as a non-inferiority trial, and we hypothesized that 6 months of DBT wouldn't be inferior to 12 months. The group, the sample included 240 people, chronically suicidal patients diagnosed with borderline personality disorder, and they were randomized to either 6 months or to 12 months. And the findings showed that our non-inferiority hypothesis was supported for our primary outcome, which was total self-harm. And there were actually fairly large effect sizes. We also found that non-inferiority of the DBT-6 was also established for general psychopathology and for coping skills. And this was at a 24-month follow-up. And additionally, an unexpected finding was that the participants who were receiving the briefer treatment actually showed more rapid reductions in borderline symptoms and general psychopathology than those randomized to the longer treatment. There was no difference between dropout rates between groups, and participants made changes on all outcomes, I should say that. So I think really the takeaway from this study, and obviously there's need for further replication of these results, was that just the non-inferiority of a briefer yet a comprehensive treatment, so 6 months of standard DBT is still a comprehensive treatment, but it has potential to reduce barriers to access. Next slide. So another programmatic approach really designed to try and improve access to therapies for BPD includes a focus on stepped care and also stage care models. Probably there's been more discussion of stepped care in the literature, but I think, and maybe just to highlight the difference between the two, stepped care is a system of delivering healthcare so that the most effective yet least resource intensive treatment is delivered to patients first. Whereas staged care really emphasizes matching people to the appropriate stage of intervention at the first step. So both models are really designed to facilitate the allocation of scarce resources, and current program models often have two steps: a very minimal intervention or a more extensive intervention, oftentimes 12 months. There's not a lot of data, though, to guide people around which step should people be in or which level of intensity. And it's really important, if we're going to understand better how to stage treatment, we need to know where patients lie on a continuum of illness and how to appropriately match them to a suitable level of care. One of the steps we'll be taking in our DBT 6 versus 12 months trial is to look at which patients might do better in the shorter treatment and which patients might require a longer treatment. Next slide. So Lois Choi proposed a model of how to organize a step care program, and this is a theoretical model, it's not evidence-based, but I think importantly her model really encourages to think about avenues to provide care for people that go beyond just thinking about specialist therapy. And I'm not sure how well you can see this slide, but essentially she's recommending that specialist therapies be reserved for people who are moderate or who are severe, but that we consider other treatment options for maybe people who are preclinical or mild, options such as psychoeducation or case management or maybe DBT skills as a standalone intervention. And then she also proposes that for patients who are quite chronic and persistent and really are not showing much progress in their treatment, that we might consider a more generalist approach or supportive therapy for them. So I think it's useful to be considering alternative pathways to try and address the bottleneck that's currently created if we only are offering specialist treatments. And next slide, please. As I mentioned, there's very little research that's looked at stepped care. This is an example of a study that was conducted in Australia to look at a stepped care model. And the study included really two cohorts. I'll talk about them together, but there were two cohorts in this. And essentially, the intervention was a 4-session, very brief intervention within a broader program. And the brief intervention was designed to provide people with some coping skills and some education. This was designed for people with personality disorders, not specifically BPD, although I think many of them met criteria for BPD. And what they found was that the vast majority of people actually did attend at least one session. And furthermore, what they also found was that in terms of symptom change, there was significant reduction in borderline personality disorder symptom reduction severity, as well as reduction in distress following the intervention, in addition to an increased quality of life. They found the largest reduction in terms of suicidal ideation. So I think it's important. Obviously, there's a replication of this needed. We're actually looking at this model and testing it right now in Toronto, in our hospital, and using it as a really first stage for people showing up to an emergency room. So we're looking at the value of whether or not this very brief intervention may be a useful step between an acute care service and a longer term treatment, because the reality is, you know, in our setting, but also in many settings, people can't quickly access specialist care. And even though they may require specialist care, it's not immediately available. Next slide, please. Another direction that the field is taking, and this is largely based on secondary analyses of randomized control trials, is looking at subgroups of people with borderline personality disorder who may not respond as well to standard specialist treatment. And there is growing awareness that in particular clients diagnosed with comorbid post-traumatic stress disorder don't do as well in standard treatments. So there's been a movement to try and offer integrated treatment that addresses both BPD and post-traumatic stress disorder. And, you know, a lot of this has grown out of the realization that single disorder treatment, whether it be PTSD treatment on its own or whether it be a BPD specialist treatment, generally are not doing as well with patients who have this comorbidity. So DBT, I think, has taken a lead in terms of adapting treatment for people with comorbid post-traumatic stress disorder, and a lot of the work that has been done has been led independently by Martin Bohas in Germany and Melanie Harned in the US. Melanie Harned and Martin have both integrated prolonged exposure within the context of standard DBT. They've also included a focus on education about the impact of trauma. Martin Bohas's model also includes additional skills for developing self-compassion, addressing motivation, and skills to address trauma. Next slide, please. Thanks. And the following slide just provides the results of a subgroup analysis that was conducted in the context of a randomized control trial that compared DBT adapted for post-traumatic stress and borderline personality disorder compared to cognitive processing therapy, which is an evidence-based approach for post-traumatic stress disorder. And this subgroup analysis was carried out with 93 people who had the dual diagnosis of BPD and post-traumatic stress disorder. So it was a subgroup within this larger trial. The results showed that both PTSD and BPD symptoms significantly decreased in both treatment groups. And when they compared treatment groups, they found that DBT PTSD was favored for improvement on post-traumatic stress disorder, borderline personality disorder, and also dissociation. There weren't between group differences on depression and global functioning. Next slide. And then finally, I want to highlight just, I think, another promising direction in terms of improving treatment. And it really has to do with the development of maybe not so much new therapies, but rather modules that are directly targeting pathogenic mechanisms associated with psychopathology. You know, I mentioned already, there is certainly work underway identifying mechanisms of change in therapy. And one good example of this work is work conducted by Sabine Herpertz and her colleagues. They developed a treatment module that's called a mechanism-based anti-aggression therapy. And it was really developed to target the mechanisms of aggression and borderline personality disorder. So based on behavioral and also neurobiological data from their group and other groups, they identified target mechanisms that would be associated with reactive depression, such as sensitivity to threat, hypervigilance to social threat, failure to recognize social safety signals, a tendency rather than avoiding social cues but approaching, and also difficulties regulating anger, for example. So this treatment module that was really designed to target aggression included strategies from mentalization-based therapy as well as dialectical behavior therapy skills training. And in this first study of this intervention, there were 59 patients with borderline personality disorder and overt aggressive behavior. They were randomized to this mechanism-based intervention or a non-specific intervention. The primary outcome was externally directed overt aggression. And if we shift, and I should say the treatment duration was 1 individual session in 6 groups. If you shift to the next slide, please, thank you. What you can see here is the mechanism-based intervention was superior to the non-specific psychotherapy at 6-month follow-up on the primary outcome of overt aggression. So I think it provides some potential ideas about how we can target specific mechanisms and then ideally design potentially modular treatments that we could use to tailor to address individual client needs. So in summary, really the last 30 years, I think, has given rise to a range of effective therapy options. And in the coming years, there just are problems that we need to continue to address if we're going to improve therapy. More research is needed on how we can adapt or extend specific therapies, in particular for distinct and vulnerable subgroups of patients. And certainly that work is underway. We also need more research, there's very little to inform us about how to stage therapy. How do we allocate or match patients to the right level of care? And that's necessary if we're going to improve access. We also need to identify the active mechanisms of therapy if we're going to have hope at optimizing the therapies that we're working with and improving outcomes. And then finally, I think another direction that is going to be important is ongoing work that's targeting the development of mechanism-based treatment modules that may target individual dysfunctions and deficits. So thanks for your attention. I will stop there.
Oh, thank you very much, Shelley. It was an amazing talk with quite a bit of ground covered. And so if we put the two talks together, we have quite a bit of ground to discuss. Perhaps, Marta, you want to introduce the next section of the webinar.
Thank you, Martin, and thank you, Sherry and Sven. Yeah, we will now have a short break, about 5 minutes, so we can all gather ourselves together, and then we will come back to you with our panel discussion, where the 4 of you can discuss what was just raised during the keynote talks and more, of course. So let's have a 5 minutes break, and once again, thank you to our speakers joining us live and to our audience, and see you back shortly. Thank you. Welcome back after our short break. So let's now proceed with our panel discussion. And first of all, I would like to give the floor to our host, Professor Martin Dibany. There you are. Thank you.
Thank you, Marta. So welcome back, everyone. We have the pleasure now to have a discussion with our two main speakers, and I'd like to introduce Dr. Gita Jacob, who is a licensed CBT therapist who first did a postdoc at the University Medical Center in Freiburg and the University of Freiburg. And her main field of interest is really borderline personality disorder with a focus on schema therapy, as well as emotion-focused techniques. And I think that a lot of the originality of your work, Gita, is around digital therapeutics and really creating software that can assist therapies, namely in BPD, but also in a broad range of other indications such as pain, diabetes, and psycho-oncology. So your books are very well known and translated in numerous languages, so people will be interested in looking these up, and we're also very interested in your view, perhaps, and maybe we'll start with you, Gita. In your view around mechanisms of change, and perhaps in listening to many of the problems that, for example, Svenja raised, the measure problem, the statistical model problem, how we actually assess these and target these, and also perhaps some of the propositions coming from Shelley around how our field is moving towards stepped care, staging, and providing not only clinician expertise but also system expertise, in a sense, in terms of being able to deliver the right kind of a module or therapy. How do you see this in the context of mechanisms of change from your perspective, Gita?
Yeah, sure. I'm very happy to share some thoughts. And I was really amused by Svenja's remark that the few studies investigating mechanisms of change only investigated their own mechanisms of change, so to say. That's funny in a way, or not very scientific in a way, but anyway. I would like to make two cases, thoughts which came to my mind mainly when listening to Shelley's explanations, and according to my experiences with borderline patients with DBT and schema therapy, and also with treating a large number of patients with digitalized treatments, I more and more have that's a very personal impression that's not so much based in scientific evidence, that it's not so much about which method is the best one, or that it's not so much about differential indication, like this treatment is perfect for this patient and treatment B is perfect for the other patient. But it's rather that there's a certain group of patients who has high expectations that treatment will help them, and who kind of get familiar or grab just any convincing model you would show them and teach them, and are somehow able to use it for themselves and get the message what they should change, and then they change, and it doesn't matter so much whether that's DBT or MBT or maybe schema therapy. And meanwhile, I think that if a couple of a patient with a high expectation in that psychotherapy will help them, plus a therapist who's also has a good expectancy, can can achieve very, very good results no matter which treatment they actually use. And it's very fascinating to see what Shelley showed that 40 years ago BPD patients were untreatable, and then like 20 years ago they needed like 2 years of treatment, and meanwhile Shelley gives them 2 sessions of treatment, and that's all similarly effective, so which speaks much in favor of this idea. So I would really like what you think about it, that it's mainly about a patient being optimistic and just doing something with what they learn. And the second case is, Shelley mentioned this briefly as well, that I think oftentimes, particularly in BPD, the social perspective is underrepresented. We officially, all our models of chronic conditions, both mental and somatic conditions, are officially, so to say, psychosocial. But in our field, in the psychotherapeutic field, we only focus usually on the psychological parts. And Shelley mentioned that many of the BPD patients stay in very, very poor social functioning conditions. And Svenja mentioned that familiar and relationship functioning is very important mediators of the few mediators you find. So my claim would be that it would be so important to offer more social treatment, like social worker treatment. And Shelley mentioned this briefly with regard to the very chronic patients, but I think that's not restricted to them. So these are my 2 cents I would like to add, or which came to my mind when listening to you.
Shelley, I thought you might want to comment.
Well, I'll just maybe just one initial comment, just a correction. It wasn't 2 sessions that we had. I think you might have said 2 sessions. It's 6 months that was non-inferior to 12.
But you also had this 4-session treatment.
Oh, the 4-session treatment, and that was not my treatment, but it's a treatment that was developed by Bryn Grenier and colleagues in Australia. So it's true, they did get.
They had good effects as well.
Compares. They had some significant findings. I don't know how it compares to a longer treatment, so we don't really know. But certainly, as I think a first step when nothing else is available, it's not a bad idea. Yeah. But with respect to your comment, maybe just to, do expectations matter? I suspect yes, and there may be a study, and Svenja, you may know of it. I don't know of anybody who's looked at expectations yet in psychotherapy outcomes in borderline disorder. I think we have data, but we haven't looked at it yet. I have no doubt that probably they do matter, and I think there's a variety of moderators that will matter and make a difference. I mean, there's some research that, on moderators, and not a lot of research, but we did an evaluation of looking at multiple moderators that might predict who would do better in DBT compared to general psychiatric management. And we found that those who had higher levels of childhood abuse, higher levels of poor psychosocial functioning did much better in the DBT treatment compared to the general psychiatric management. Whereas actually, contrary to what perhaps a lot of people might think, the general psychiatric management condition did better this is predicted models, it wasn't, did better in the GPM rather than the DBT on self-harm. So again, that's, often people think of DBT as the treatment for self-harm, but I think it helps to shatter the myths that we have and just provide some evidence to really look at what makes a difference and which treatment approach for whom.
That's very interesting. Svenja, I wanted to bring up something that you mentioned in passing regarding the mechanisms of change, and perhaps you mentioned this meta-analysis on adolescent treatments, which it seems that we're not doing very well, and then you mentioned in passing that there might be specific mechanisms of change in adolescence. Could you elaborate a bit on that?
Yeah, I hope my connection is better now. I got thrown out here, and
we can hear you.
Yeah, that's great. Okay, so I mean, what we could find in this review was that the peer relations do play a role in adolescence. So maybe you remember your own adolescence. So this could be more important than the relationship with an adult therapist. So this should be addressed more. And at the moment, there is no treatment aside from systemic treatments that do address peer relations actively. So we know that from externalizing disorders that they really profit if the whole network is included. So this could be one way of improving the treatment for BPD in adolescents as well. I mean, in MBT, we do have a concept for family work in BPD. Not all the protocols use it, but looking at the mediators, it should be very important to also include family work in this. Yeah. So these are two important things. I was surprised that the coping skills, that did not turn out to be so great. So in one of the studies that looked at changes in DBT for adolescents, it was only change in emotion regulation that predicted outcome, but not the new coping skills learned in skills groups, for example. But I have to say it's very, very selective results from very, very few studies. So. But I would recommend to develop something specific to adolescents and not just take a somehow less complicated version of an adult treatment, because it doesn't seem to work, actually.
It seems your point on family joins up with one of Gita's comments on the social environment.
Absolutely, yes.
Yeah.
It's about just having a proper and good life.
Yeah, and it seems that, I mean, from my perspective, but perhaps you have data on this, we're not yet doing a very good job of analyzing the interactions between, for example, family therapy in MBT and individuals therapy, or between family connections groups that you might have in DBT. So do you have any evidence, or is this something that's coming up as well, Shelley, in terms of really looking at, like, progressively looking at changes in, the ways that the families are dealing with the issues, and how that can either precede or follow any kind of changes as therapy goes on? Or do we have any kind of data on rhythms that could be of interest to the clinicians that are listening in?
Yeah, I don't know, Svenja, if you wanted to comment on anything that came up in your review, whether there were any adjunctive family interventions.
Yeah, well, not in the BPD treatments, but in systemic treatments. But I was just reminded of a study that Anthony Bateman, for a while ago, that he was just treating relatives and not the patients themselves, and they. Just by seeing and doing psychoeducation with relatives and like kind of teaching them how to deal with their borderline relative, it did change the symptoms in the borderline patients. So I think that would be a really good way to go there. But what we haven't touched yet is the stigmatization issue, because this is one of the major problems, I think, in BPD, that they still have such bad reputation. At least in Germany, they do. So whenever they encounter social services, they are so severely stigmatized, and they don't expect them to be better. So there's still this idea of an untreatable illness and a very difficult person that I should rather not engage with, because it's not working anyway. And the social workers try to protect themselves by disengaging with these patients. So I agree with Gita here that we need to do more with the social environment, also the professional social environment that they have.
Yeah, I agree. I mean, certainly much of the research, I think, has focused on, say, family connections or other family interventions, have predominantly looked at outcomes in family members rather than also looked at the impact on youth, to my knowledge. I'm not sure, Svenja, how much you've reviewed that literature, but I think more of it is focused on outcomes for families. And certainly that's an important area to focus. Oftentimes families are the ones who are completely burnt out and stressed, and no doubt contributing to the problems further. And there is research that indicates, and we've certainly done some of this, looking at the impact of, say, groups like Family Connections can have, just in 12 sessions, have a big impact on reducing family stress, reducing their burnout, I think enabling them to cope with skills that would be more effective. But I think it also sort of this idea of training up families and support for also health professionals, I think also relates to the whole conversation about how can we scale up our therapies, because I do think we need to go beyond specialist therapists and look at how can we leverage resources in the community that will, facilitate growth and change in individuals. And that, would be involving family members and peers and teachers. And I think that will be an important kind of path to enhance scalability of interventions.
And indeed, some of your work, Gita, may also be applicable to higher scalability in terms of access to the digital tools.
Sure.
Yeah.
Sure. Well, our digital interventions simulate treatment for the patients themselves, not so much for family members or else. But of course, we currently are running an RCT investigating a schema therapy program for BPD patients, and looking forward to see what comes out. And we are also developing a second product for BPD patients, which is more, which has a broader therapeutic approach, I would say, like the best of psychotherapy for BPD patients. Eva Fassbinder is very much involved here. He has very broad experience with those patients. Of course, that's easily scalable because you can give it to as many patients as you want. And we also see that there's of course, a large variance of effectiveness. So some patients just get a lot out of that and others don't. And obviously, there's also quite a group of BPD patients who use loads of treatment and don't benefit.
So do you have a sense of how clinicians can think of digital tools, and when could they eventually, indicate some of the resources? Do you have a sense of in which profiles or in which situations you would recommend this?
Well, the approach in our company is to develop programs which can be used by a very broad range of patients, and which don't need an active involvement of psychotherapists or physicians, because then it's scalable and practical. And we believe that it should always be the decision of the psychotherapist or physician whether to offer such a product to a patient or not. In studies, we see similar effects of our programs as compared to personal psychotherapy. But of course, you would also not offer all patients the same kind of psychotherapy. So it should be the choice of the psychotherapist. And again, the psychotherapist should have a positive expectation with regard to the product, because this will mean a lot to the patient. And if the therapist asks the patients about their engagement with the program, then effects increase enormously. So if the patient feels that somebody, maybe the GP or whatever, is interested in whether they use this treatment and what kind of experiences they make, then they will engage much more and benefit much more.
I thought you might want to talk. Sorry. Moving on, I'm. As we increase the different kinds of therapies, or as we, get to know more about the moderators or the mediators and the mechanisms of change, I have to say, and this is to perhaps provoke a bit of debate, I'm a bit concerned about the training question, and I know that a lot of people tuning in are in their training. And my concern really is that we're throwing a lot of, let's say, exciting evidence out there, but that in a sense, it's not always that clear for the people on the ground where to start, where to go, and how to understand it, what to use, and what are the skills that they should need to focus on in their stepped or staged training, as it were. I'm wondering, Svenja and Shelley, whether you have similar concerns or perhaps even solutions or reflections upon this.
First of all, I have to cope with the idea that I'm not needed anymore if I can use a computer program that's as effective as I am. But when I have survived this, so this also is thought-provoking.
And this is a very common fantasy, Svenja, but don't worry, you will always be needed. This never leads to a decreased...
Okay, so I'm hoping to have it as an adjunct version.
Absolutely.
Yeah, and I mean, my psychoeducation is most of the time not so so nice, so it would be great to have the psychoeducation modeled in here.
Absolutely, you can use it like the adjunct group in DBT skills group or schema therapy. The psychoeducation, the boring parts of your work, should be done by the program. Yeah.
And so, actually, I'm involved in another modular psychotherapy that Shelley hasn't mentioned. Because it's dedicated to chronically depressed patients with a high early adversity. So I guess a lot of them have also comorbid personality disorders, but that's not the focus of the study, so they didn't really look at it. And they combined CBT with CBASP, so that's dedicated to chronic depression, mentalization-based treatment, and mindfulness training. So they have these 4 different therapies integrated in a modular approach, and then they have an algorithm. So they give the patients questionnaires in the beginning, and when they are low in mentalizing, for example, and high in another step, then they get a mentalizing module included. And I'm actually supervising the therapists in the mentalization-based approach, and they say it's really difficult to do this, to perform this therapy, because then they have to be 4 therapists in one performing these 4 therapies. But and I think we're still not there, as Shelley said, to really stage or like to set the stage what kind of therapy is needed for what kind of patient. And by just picking out the raisins, I like this metaphor a lot, you cannot bake a cake, right? So it's not a great cake if you just have raisins in the end. Do you have that in English as well? To pick out the raisins, like to take the best? Yeah. So
it would be chocolate chips, but
I have that at home as well.
It's not raisins. Okay, so you just have chocolate, but not a cake anymore. So we still need like a framework that we shouldn't lose, or like a clinical model to understand it, even though it's a myth. I mean, coming from common factors, we know that most of our clinical models are myths. So, but as long as we believe in it and we can convey it to the patient, that's fine with them. So I'm a bit scared of these modular approaches, even though I'm in Heidelberg part of these groups, still like making out new ones.
Yeah, I appreciate your concern, and I myself, I'm also uncertain about really how, really training people in just specific modules alone just doesn't seem sufficient. Obviously, people are complex and they are, showing challenges oftentimes across a range of domains, not just one. But that doesn't mean that you can't, within a particular model, incorporate modules to address and target specific areas of dysfunction. I do think that would be the way to ultimately move towards a more efficient treatment. And I think that's actually really happening already amongst clinicians. Clinicians are incorporating skills to help people learn how to modulate their emotions, or, DBT clinicians are incorporating mentalization-based skills to try and help them work on their mental state. So I think clinicians are further ahead in this regard than the research.
Yeah, well, that's interesting because there's also, of course, the trajectory and the careers of clinicians in terms of years of experience, exposure to different types of clinical phenomena, different types of settings as well. And do you have a sense of a progression that could be useful for clinicians starting out? Anyone among you?
Yeah, I mean, we have these common factor trainings that are coming up. So this would be one way of doing it. You have like a general model of change and you're trained in common factors, which we know of, they are effective. So you know how to build up an alliance and how to repair ruptures and, so this would be one way. And then you have these particular specific techniques that you can use for a specific problem that a patient has. So this could be the future of psychotherapy. Why not?
And it is, I think it is a direction many places are going. Certainly, if I look at what's happening in the Department of Psychiatry at University of Toronto, that is the approach that we've taken. We're training people up first off in common factors. And that's the first year. And then the second year, they delve into two specific models, so CBT and then psychodynamic. And they have half a year on CBT and then they move into psychodynamic. So I think they get immersed in different models. And I mean, I am a proponent of actually people really learning a model before they start integrating. I think learning common factors is an initial first step, basic empathic listening, basic skills to manage ruptures and cultivate an alliance are, I think, essential. And then moving into really immersing oneself in a model. And I think once you're immersed in a model, it becomes then easier to step back and look at how to integrate other elements and potentially other modules.
And I would add to always, particularly in chronic patients, always have a look at the treatment history of the patient. And if you see a patient who did not respond well to maybe even a couple of treatments, then just accept that the number needed to treat in psychotherapy is also like 3 or 4, and maybe that's rather a person who might benefit more from social work and not from a more elaborated or better integrated or even more complex treatment approach.
Yeah, coming to what I thought was perhaps less included in your talks were indeed the data on therapists, and we know that from work from Bruce Wampold and other people, there's actually a significant amount of variance explained by therapists, and we're very much focused into ameliorating treatments. But again, my questions here are turned towards also therapists. Are we doing enough? In your mind to actually support and increase either the basic skills of therapists or case formulation some of the critical things that you mentioned, Shelley, are, when to give what concerning the clinical needs. So, what is your feeling here? Are we doing enough for our clinicians?
I can say no. You know that when you introduced me, I do training research, so I know a little bit about this. So, I mean, the therapist effect is significant, but not as high as you might guess when you are trained psychoanalytically. Then you maybe overestimate your impact on the patient. So this could also be one thing. So it's 6% of the, of the variance explained on average. But the sicker the patient gets, the more important is the therapist. And we know from the treatment in BPD that one problem is that therapists, they lose empathy with these patients. So they really need to work on their empathy here. And I think the training needs to address that more. And we need to, well, in the classic trainings, I don't think that people are so well prepared. It's a bit too theoretical sometimes, especially in the psychodynamic trainings. So we need to get more into the process and really look at videotapes more here. I mean, MBT is very good at that, but the classic psychoanalytic training, you don't have, you don't have any material to look at. Just your own training analysis, maybe that's not really enough to learn it. So we can do more deliberate practice, structured feedback, role play, actors that serve as patients. This would be the way to go.
I completely agree with you, Svenja. I think absolutely, access to being able to see therapy tapes and to be able to do practice. We spend a lot of time in theory and talking, and I think insufficient time practicing. And I know there's certainly a move to shift the way we're training people and spend much more time, flip the classroom and spend much more time in the practice and far less time on the didactic teaching. Just to go back to your question about the role of the therapist and the effect of a therapist, we just published a study looking at the relationship of the alliance with outcome in a sample of borderline patients, and you can decompose the alliance to look at the therapist effect. This is based on Bruce Wampold's work, or the effect of the client, and actually really in contrast to other studies, and I think it's important because many other studies have not been done with personality disordered patients, but in contrast to other studies, what we found is it was the client, not the therapist contribution to the alliance, that was significant in predicting outcomes. And I think it's important because I think, to me, it highlights that they're really, first of all, when you're working with a more severe population, oftentimes it is therapists just do face challenges with how to intervene with very severe people that are, and I think there's just areas that we don't know well, for example, how to intervene. Gita, you gave the example, the person who's been chronically in the healthcare system and hasn't made progress. I saw somebody recently who was exactly that sort of situation where there really had been no progress, and that was the problem to solve, but we don't really have a solution for how to address that problem with that client. We don't really have good therapeutic techniques to know how to intervene effectively with a patient like that. So I think we're not there yet with some people who are not responding well to the therapies, and we need to learn more how to do better.
But isn't that maybe part of the problem, to expect of such a patient that there still might be some technique which might be the right to help them make a U-turn? So I suspect that some patients simply will not respond to psychotherapy, and sometimes it might be better to admit that we may not be able to help them with psychotherapy methods. In integrated care, you might then involve a social worker, for example.
No, that's a fair, totally reasonable point. I tend to be an optimist, so I hate to give up.
Yeah, I have to. Yeah, I'm provoked by this statement as well, because as a psychotherapist, you always believe that there's some way to help a client. I mean, we have developed in Heidelberg a treatment for antisocial youth, and this is a group that's not very popular among psychotherapists, and they have also a bad reputation that psychotherapy doesn't work with them. But in my view, there is a problem in the right dose or in what we offer them. So when they get group treatment, they learn delinquents, and then afterwards we say, oh, they're untreatable. So I think there is something in the mechanism-based approach that you understand better what is actually what you need to change here, and you cannot apply everything to everyone. So I mean, this would be against the common factors. So the common factors is a good base, but then you need to look specifically at the person, not the diagnosis, obviously.
I know that therapists are always optimistic, and I like this in a way, but the training I give is more in the group of experienced therapists, like advanced workshops or supervision workshops or peer supervision with very experienced therapists, and they also see these patients Shelley just mentioned. And I mean, evidence shows that there are loads of non-responders in studies, and that it's rather certain patients who do not respond to different treatments, and not so much that there's one right treatment for simply every case you may see. So I sometimes think we're too optimistic and we're not realistic anymore, and this actually adds to this lack of empathy you eventually experience as a therapist, because eventually you're so annoyed with the patient just keeping complaining about their condition but not improving, and sometimes it might be better to admit, well, maybe I cannot help you. But I absolutely agree that it's very much against the usual training culture in psychotherapy.
I want to make one plea for the thinking out of the box and be creative. So for some patients, you just need to be very creative. I was just thinking of one of my patients that I had during my residence in psychiatry. I got all these patients that the others had lost empathy with, and I found out he couldn't read. So in the therapy sessions, we were actually practicing reading, so he could participate better. And I got him a small job, and he earned a little bit of money, and he wasn't suicidal anymore. So there was but maybe this is the argument that you were giving. So we don't need to do so much psychotherapy. We just need to see what is the need of the patient. And maybe it's not psychotherapy at all. It's just learning to read.
Wow, and that's what I would call rather the social part of the treatment, and not so much a very, very sophisticated psychotherapy method. Fantastic example.
Maybe you're right.
Let's take a question from the audience. We have a first question. I think this one is for Gita. Can you tell us a bit more about STEPS, group treatment?
Oh no, this is for Shelley, I think.
Oh, sorry. Is this for Shelley?
Unmute. I'm by no means any expert in STEPS. That's not an approach I've been trained in, but STEPS stands for System Training for Emotion Predictability and Problem Solving, and it's a 20-week intervention really designed, I think, initially for people with BPD and severe emotion dysregulation. It's largely a skills training focus, sort of combining sort of a cognitive behavioral intervention with also a system component to it.
Okay, thank you. As we take other questions coming in, maybe I'd like, before we end, to address the very interesting issue that Shelley raised around post-traumatic stress disorder, comorbidity, as well as the notion that individuals go through perhaps neglect trajectories that are chronic, as well as abuse that makes it that brings an extra challenge to everyone, really, in trusting perhaps people within therapeutic interventions. So I'm wondering whether You could a bit elaborate on that, perhaps Shelley and Svenja.
Yeah, sorry, I'm trying to remember exactly the article that was recently published. I think it was in JAMA, recently published, just documenting the high levels of not just PTSD, but emotional invalidation in borderline personality disorder. So I'm not sure to elaborate on it. I think that, there is, there's been historically this divide between the treatment of trauma and the treatment of BPD. And I think that's actually oftentimes been highly political, the reason for the divide. And I think what's nice to see is there is a merging of these fields, because I think it's very relevant. The work that's been done in the PTSD field is highly relevant to treatments for people with borderline personality disorder. So I think that the work that's been undertaken, in the DBT area, and I understand in mentalization-based therapy, there's also work underway to increase a focus on the treatment, concurrent treatment of post-traumatic stress is really important. I think there's been a long-standing concern, and I think there's still some skepticism about how to achieve that. What level of stabilization is required before you can move people into, deeper processing of traumatic emotions. And I think that, historically the view was, and I can understand why there was a view, certainly dating back to early analysts, with the fact that many of our patients are going to destabilize if you start uncovering painful, traumatic emotions. And I think that that is a risk in standard treatments. And I think that the two treatments that I'm most familiar with, so Melanie Harned's work, DBT, which includes prolonged exposure, and Martin Bohas, which also includes prolonged exposure, there is a phase that focuses on stabilizing people before they delve into deeper emotion processing work. And it's there because a lot of people do have difficulty with destabilization as they're starting to experience painful emotions. But I think what's, I think an important development is that it was previously thought that people required at least a year to stabilize before they could move into that work. And I think now there's realization it can happen a lot sooner. Often within, you can help people get stable behaviorally, emotionally within 4 or 5 months.
Yes, I agree here. We are developing this for MBT at the moment. It will be called MBTTF, trauma focused is the word. And we will also integrate from other approaches. For example, for the adolescents, we will integrate bottom-up approaches. So like sensory motor psychotherapy to talk about the body, to regulate the body. But it also starts with building up resources first. So with the adolescents at the moment, we also use animal-assisted therapy. I'm working with a group of traumatized adolescents, and we go to the alpaca farm and we practice mindfulness, directed mindfulness on the animals, because those kids cannot practice mindfulness on their own in the beginning because they're flooded with traumatic memory. So they can actually use the animals to go into that direction and build up this resource that they need for reprocessing traumatic memory. And I wanted to say that one problem in classic psychotherapy is that there's a danger to overlook traumatic experience, especially in adolescents, because they don't have the classic PTSD symptoms yet. So most of the antisocials that I treat, it turns out that they have severe traumatization in their background, which can be overlooked because they don't identify with their traumatic experiences, and they don't want to share it necessarily because they have low trust in others. So it does take time to reveal what was actually there and to see their problems as a consequence of trauma, actually.
Actually, just on a related note to what you're saying, Svenja, we're also taking the work that Martin Bohas has done in the DBT PTSD, he's adapted it for traumatic invalidation. And we're running a study right now in Toronto and in Germany looking at the application of treatment for the traumatic invalidation, but in a population that doesn't meet criteria for PTSD. So they meet criteria for BPD, but not PTSD, but we're treating them for their traumatic invalidation because the vast majority have experienced significant emotional invalidation.
Yeah, so that's very interesting work, and both from the stabilization point of view, but also the focus that seems to be needed, and also perhaps sometimes in adolescents or other individuals that are very much in a sealing over state, that there needs to be some kind of introduction to the links that might actually exist that they're not seeing. So that's fascinating. As well, you mentioned briefly, Shelley, there's a lot of neuroscience also going into the mechanisms that are involved both mentally, but also very acutely around these effects that we are learning as we are going, today and tomorrow. A lot of studies there are unraveling some of the mechanisms from a neuroscientific point of view. So that's very much a source of inspiration, probably in the development of future interventions. So we're coming to a close here. I'd like to thank everyone for participating in this webinar. I hope for the people at home this was as exciting as for myself. And I will give back the mic to Marta. If she can hear me. There she is. Or
I'm here.
All right.
I'm sorry. Thank you very much to everyone here, and thank you to the audience. So this was our third webinar. Our fourth will be in September, and all leading once again to our EACLIPT 22 conference that will be in Warsaw on November 11th and 12th. So do check us on the website. And once again, thank you everyone, and see you in September. Thank you.
Thank you, Gita, Svenja, Shelley. Thank you.